Hello, doctors. This is Dr. Bruni here. Please let me know if you can hear me. Let me know if you can hear me right away so that we can get a game started. If you can hear me, let me know. Let me know where you're joining me from, whether you're joining me from Canada, South Africa, Saudi Arabia, India, all over the world. Wherever you're joining me from, please. Beautiful. So I'm getting some confirmation that yes, we can hear you. Yes, we can hear you. Yes, we can hear you. So this is awesome. Okay. Um, all right. Thank you very much. Please make sure you invite as many friends as possible to join us so we can get through this class. As I said in our WhatsApp group, this afternoon's class is going to be very extensive. We've prepared more than um, 88 slides. Okay, so that is Dr. OJ for you. Beautiful. That's good. Just had a conversation with her. So we've prepared more than 88 slides to review today. So please, kindly make sure that you've gotten some water or something so that you can stick with the class. So I'm just going to dive right in because it's going to be a very extensive class. Let me plug my charger. Okay, please let me just plug my charger right away. In the meantime, please don't forget to click on the YouTube channel subscription. Kindly subscribe. Okay. Also share to as many friends as possible. Please do that. So then let's get it going. Okay. So I'm almost done with connecting my power. Okay. So now let's go. Approach to somatic symptoms and related disorders. Okay. Somatic symptoms and related disorders. And we're going to go through our rationale again as we do every time. So the rationale is that prominent or vague somatic symptoms are common presentations. Remember, this exam is about common presentations. Common things are common. And through every objective we've done, we see that word when they are describing the rationale. The only one we've not seen that word was what we did last week, which was polyuria and polydipsia, right? But then the medical council made a comment that even though it is not very common, it has very dangerous consequences if it is not picked up. So you realize that I always tell you that in the MCCQE1 exam, prepare, to make sure that you keep the patient alive, all right? Stabilize the patient. That is why a lot of emphasis in the MCQ1 exam is also placed on acute care. You are going to get about 45 to 55% of questions coming from acute care. If you look at the way the medical council breaks down the way they distribute the questions, right? So that is something you want to pay attention to. Okay, so prominent or vague somatic symptoms are common presentations in primary care and other medical settings. Okay, these symptoms are often accompanied by significant patient distress and disability, but do not have consistent pathophysiologic findings. Now, the causal conditions: number one, psychological factors affecting other medical conditions. So that's a whole topic on its own. Number two, malingering or factitious disorder. Okay, so if you are preparing for this exam, make sure that all these topics I'm mentioning, you are reviewing them. Number three, substance use disorder. And in substance use disorder, make sure you've covered your alcohol, opioids, amphetamines, cocaine, like all those ones, right? And for those in MedCognito, we've already done all that in your emergency medicine portal. Okay. And then other psychiatric disorders like somatic symptom disorder, illness anxiety disorder, conversion disorder, postpartum stress disorder. Okay, and today I'm going to drop some wonderful questions as we go through today's class, which will also touch on some of these other topics and adverse life events like adverse childhood events, intimate partner violence, other traumas, adults' physical abuse. Okay, now the key objectives: giving a patient with prominent or vague somatic symptoms and significant distress causing disability without consistent pathophysiologic findings, the candidate, that is you, will consider a somatic symptom type disorder. All right, and that's exactly what we are doing right now. And then the enabling objectives. So please, if you realize every objective goes through rationale, causal conditions, main objective, enabling objectives, right? So given a patient with symptoms consistent with somatic symptoms or a related disorder, the candidate will, number one, list and interpret critical clinical findings, including potential contributing conditions identified through appropriate history and physical examination. Number two, integrating current history and findings with information from available medical records. All right. Number three, list and interpret critical investigations, including an alcohol and recreational drug screen. That's why I was talking about all those recreational drugs, right? Alcohol, cocaine, LSD, fentanyl. You know, you have to always ask yourself, currently Canada is going through an opioid addiction crisis, right? And that's even an opportunity for doctors who are into psychiatry, internal medicine, family medicine. You know that you can do a +1 in addiction medicine after your family medicine residency, and that is something I would really encourage you to look at. And if you want some more information about that, you can always reach me at +1 306 891 5649. That is the number which is scrolling at the bottom of your screen. Okay, especially addiction medicine, because it's a serious issue now, and Canada needs a lot of doctors in that field as well. It's a very wonderful field. I do addiction medicine myself, and you know, it's always great to bring relief to other people. Okay, and it's wonderful to be part of their journey as well. So investigation of new symptoms where appropriate, and no further investigations where appropriate. And number three, you want to learn to construct an effective initial management plan, okay, including educating the patient about the connection between physical symptoms and psychological distress, and appropriate pharmacotherapy as indicated, and referring the patient for specialized care if necessary. One thing I realized was that whenever I go through this and then I introduce a topic, most of the time my first question is about that particular topic and everybody gets it right. So what I'm doing is, today I'm not introducing the topic first. I'm going to set a question, and when you've answered the question, then we'll go into the question. So let's start with one question, please. Are we ready to roll? If we are ready to roll, just type ready to roll, ready to roll, ready to roll. And please kindly subscribe to the YouTube channel, man. Let me just go there and check where we are now. You are helping us to grow it. But before we start the class, please just let me know. I'm ready to roll. Click on the subscribe button right now and then give us a thumbs up as well. Give us a thumbs up, give us a thumbs up, give us a thumbs up. So click on the subscribe button and then give us a thumbs up. Let me see, where are we now? Where is MedCognito on YouTube? So please go there before we start the questions and reviewing everything. Please go there, click on the subscribe button. We are at 1,854. So please, doctors, by the end of this class, we need to hit 1,900 subscribers. 1,900 subscribers. So we have about 46 people to just click on the subscribe button to get us to 1,900 subscribers. Please, let me see the real-time subscribers right away. Okay, give us a thumbs up. Yeah, and then so let me know. Ready to roll, ready to roll, ready to roll. Okay, beautiful. Now let's start. As I said, I'm not going to introduce a topic in the enabling objectives today or the causal conditions. I just want to go through this question first, and then the question itself will come up. So, a 62-year-old man with a history of hypertension and type 2 diabetes mellitus presents to the clinic for a follow-up. His blood pressure remains elevated at 160/95 millimeters of mercury, and his HbA1c is 9.2%, despite being prescribed amlodipine, metformin, and insulin. Upon questioning, the patient reports forgetting to take his medications most days and expresses frustration and irritability about his diagnosis. He does not exhibit symptoms of major depression, but states that managing my health feels overwhelming. Which of the following best explains the patient's condition? A. Functional neurologic symptom disorder. That's conversion disorder. B. Psychological factors affecting other medical conditions. That is PFAOMC. C. Somatic symptom disorder. D. Generalized anxiety disorder. And E. Major depressive disorder. Doctors, let's go. Click on the like and subscribe button on YouTube so we can get this to as many doctors as possible, because we love to hear from you. We love to connect with you on YouTube. So, doctors, is your answer A, B, C, D, or E? Okay, so good. This is beautiful. A lot of doctors are going for B. Dr. Irene went for B. Dr. Victoria went for B as well. Dr. David went for B. So it looks like all of us got it right. The answer is B. Celebration Collins. No, it is not C. I know your name has Celebration Collins. That is CC, right? But the answer is not C. The answer is rather B. Celebration Collins chose CC. Celebration Collins, right? But the answer is B. So it is psychological factors affecting other medical conditions, PFAOMC. And what do I mean by that? This patient's persistent non-adherence to treatment and irritability without another mental disorder significantly impacting without another mental health disorder significantly impacts his hypertension and diabetes control, and it makes PFAOMC the best diagnosis. That is B. Okay. Now, let me go with C, because that is where some of us also got it wrong. Why is somatic symptom disorder incorrect? It is incorrect because the patient is not excessively preoccupied with somatic symptoms. Okay, so with somatic symptom disorder, you are looking for a patient who is excessively preoccupied with his physical symptoms. But this particular patient, he is rather struggling with adhering to using his metformin and his insulin. All right. Now, what about functional neurologic symptom disorder? What are the features? And what are the features which separate it from psychological factors affecting other medical conditions? So, functional neurologic symptom disorder, which was A, is incorrect because the patient does not present with neurologic symptoms. So, in conversion disorder or functional neurologic symptom disorder, look for that patient who, like, you've done a head CT, you've done everything, looking for why the patient is experiencing those specific neurologic symptoms and there is none, right? And it could be that maybe the patient went through some very stressful life event and then the patient is already paralyzed. That is, when you're thinking about functional neurologic symptom disorder, that's what you have to think about. What about generalized anxiety? We all know GAD-7. We all know the features of generalized anxiety and major depressive disorder. Okay, so I'm not going to bother you on that. But with major depressive disorder, you're looking for patients who have persistent sadness and hedonia. They are not interested. They are lacking sleep, right? And then generalized anxiety disorder is incorrect because the patient's distress is focused on managing his chronic disease, not on every other aspect of their lives. Doctors, please. So that is the first thing. And I'm using this question to introduce today's topic. So today's topic is the first causal condition in the causal conditions, psychological factors affecting other medical conditions. Okay, so we are going to focus on psychological factors affecting other medical conditions, which some authorities call PFAOMC. Others also omit the O and make it PFAOMC. All right, so each of them is okay. It's just an issue of nomenclature. So what you have to understand is that PFAOMC is a two-way street. Okay, it's a two-way street. It's a relationship between the mind and the body. Sometimes patients' thoughts and their emotions and their behaviors make a medical condition worse. So like the case we just dealt with, this gentleman has diabetes, but he's not taking his medications. And it's because he feels overwhelmed. So he has that psychological factor, which is now affecting his medical condition, which is diabetes. Okay, and then at certain times, other medical conditions also affect mental health. So this is like, a psychiatry class of a sort. Don't forget that tomorrow we have a med drill in psychiatry, and tonight you have a class as well when this class is done. So from tonight till tomorrow, it's really, really packed. So let's get going. And Hippocrates has said something, that it is more important to know what sort of person has a disease than what sort of disease a person has. So in relation to this, psychological conditions affecting medical states of patients, right? Hippocrates says that it is more important to know what sort of person has a disease than what sort of disease a person has. Because who has a particular disease can really impact the way that disease progresses or that disease is dealt with. Okay, all right. So what's the definition of psychological factors affecting other medical conditions? It occurs when a medical condition is negatively affected by psychological or behavioral factors. So the patient has either hypertension, stroke, cancer, whatever medical condition, and then there are these psychological issues and behavioral issues which are affecting the outcome of that particular medical condition. And that is exactly what we're talking about here. Okay, so these psychological and behavioral factors can make the condition worse by exacerbating it. That's number one. Number two, they can also interfere with the treatment. So like the case we started with, the patient is not taking his medications, or it can increase the risk of complications, hospitalization, or even death in that particular patient. So the key rule here is that these psychological factors should not be part of another mental health disorder. So it is that the patient has a medical condition and the patient has some psychological issues in their lives, which is affecting that particular medical condition, right? But then that psychological medical condition should not be part of another mental health disorder, like generalized anxiety disorder, like depression. It should not be like bipolar. All right. Okay, good. So let's look at some real life examples so that you can really know where we are taking this from. So I'm going to give you 3 examples. Number one is a heart attack patient who is so anxious that they refuse to take their prescribed medications after discharge. This patient was diagnosed with heart attack or myocardial infarction, but then the patient is so anxious that the very medication which will help him, he's not even taking it. Okay, number two could be a diabetic patient who ignores their diet and blood sugar monitoring due to the fact that they are in denial about the fact that they have diabetes. Okay, and it could also be number three, a transplant patient who stops taking immunosuppressants because they believe that their new organ will be fine without medication. It's not like this patient has generalized anxiety disorder or depression or anything, but then this patient has a psychological stress or a psychological adaptation to that medical condition, which can pose a serious risk to that particular patient because the patient is not instituting what must be instituted. So look, in each of these cases, their psychological state, whether it is fear, denial, or overconfidence, is what is worsening their medical condition. None of these patients have generalized anxiety disorder or depression, but then the state of their mind is worsening their medical condition. So the bottom line take-home point is this: many people with medical conditions are affected by their own psychological state, but it often goes unnoticed, and many of us don't realize it as clinicians. And that is why the Medical Council wants us to pay attention to that. So if you want to do a quick recall, psychological factors affecting other medical conditions puts patients in a trap. So I just gave you that acronym, TRAP, T-R-A-P. And the trap can make their medical conditions worse. So what are the components of TRAP? A, treatment non-adherence. Okay. B, risk of complications can increase. For example, if you have a patient with angina and the patient is always worried, and because of that, the patient is even in paralysis mentally and does not take their medication, it can worsen the complications. Number three can be anxiety. They are either anxious or they are in denial or other emotions that can affect their recovery. All right. And then number four is psychological states. It affects their physical health. So now let's dive into some questions. So please, somebody says I should go back. TRAP. Okay. TRAP. TRAP. Treatment, risk, anxiety, and psychological states. Okay. So now let's get into this question. You have a 58-year-old man with coronary artery disease and hypertension. He presents the emergency department with chest pain. Chest pain. This guy's troponins are negative, and an ECG shows no acute ischemic changes. He reports that he's been under extreme financial stress for the past 6 months and often experiences similar episodes of chest pain. His exercise tolerance is normal, and a recent angiogram showed stable plaques without significant obstruction. Which of the following best explains the likely underlying mechanism of his symptoms? So you have a patient, 58-year-old, he has chest pain, he has a history of coronary artery disease, troponins negative, ECG does not show any ischemic changes, but he has a financial strain in his life. He did an exercise tolerance test, was normal, angiogram, normal, like a stable, right? What is the answer? A, increased myocardial oxygen demand due to uncontrolled hypertension. B, myocardial ischemia induced by psychological stress. C, coronary vasospasm secondary to undiagnosed variant angina. D, Takotsubo cardiomyopathy due to catecholamine surge. E, a functional neurologic disorder leading to non-cardiac chest pain. And I see a lot of doctors going with B, 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 B. I see a lot of doctors going with that. And the correct answer is B. So this patient is experiencing myocardial ischemia induced by psychological distress. Now, Dr. Katie is asking a question. Is it E? Now, let's go to E. Remember that I told you functional neurologic disorder in the previous question is incorrect because usually in functional neurologic disorder, the patient may have to present with some form of, a neurologic deficit, right? And you do all your investigations and they'll all come back good. So functional neurologic disorder or conversion disorder is incorrect because the symptoms have a clear physiologic basis, right? You have a basis for it rather than somatic manifestation of psychological distress, okay? And the answer is B. It is myocardial ischemia, which is induced by psychological stress. Why? Because psychological stress has been experimentally shown to trigger myocardial ischemia, even in patients who have stable coronary artery disease. So that is why B is the correct answer. All right? Okay, let's go to another question. A 45-year-old woman with a history of obesity and type 2 diabetes mellitus presents for follow-up. She rarely checks her blood glucose levels, does not follow dietary recommendations, and has not refilled her insulin prescription for the past 3 months. She expresses frustration with her health and states, "I feel so exhausted and overwhelmed that I just don't care anymore." Which of the following best describes how psychological factors are affecting her medical condition? A, decreased medication adherence due to undiagnosed schizophrenia. B, non-adherence to treatment secondary to psychological distress. C, somatic symptom disorder leading to excessive preoccupation with diabetes. D, factitious disorder with self-induced hyperglycemia. And E, normal frustration with chronic diseases without clinical significance. So this is somebody, type 2 diabetic, obesity. She needs to take her medication, but she does not check her glucose. She does not follow recommendations. She has not refilled her insulin prescription, which is very dangerous, right? She expresses frustration with her health state and states that I feel so exhausted and overwhelmed that I just don't care anymore. I don't care. So what's the correct answer? What's the correct answer? What's the correct answer? I see that there's a little battle between E, which is normal frustration with chronic disease without clinical significance. But we ask ourselves, this one, is there clinical significance? Obese, type 2 diabetic on insulin, not refilled it for 3 months. That is very dangerous, right? The correct answer is B. The correct answer is B, right? This patient's poor adherence to medical treatment and lifestyle changes is consistent with psychological factors affecting a medical condition. Now, why is E wrong? Why is E wrong? Normal frustration with chronic disease is incorrect because her treatment non-adherence is clinically significant. So that's what I was saying. It is clinically significant, right? For the fact that the patient is obese, and the patient is not taking her medication. And this is increasing her risk of diabetes complications. So I can see here that what Victoria for Victory says, but there is nothing showing he's having myocardial ischemia. Well, I don't think we are talking about myocardial ischemia here. We are talking about a patient who is obese, who is diabetic, who has not filled her medication for the past 3 months, insulin and metformin, and it is a very, very clinically significant situation, right? Okay, let's go to the next question. You have a 55-year-old woman with type 2 diabetes and hypertension, presents with non-healing foot ulcers, despite being prescribed wound care and glycemic control medications. She misses multiple follow-ups, states that she doesn't feel like dealing with it right now. Which of the following best explains how psychological factors are affecting her condition? A, poor immune function due to chronic stress and depression. B, unrecognized diabetes-induced neuropathy causing wound progression. C, iatrogenic corticosteroid effects causing impaired wound healing. D, overuse of analgesics leading to poor circulation. E, normal delay in wound healing due to age. So doctors, you realize that this particular topic is like a merge between clinical medicine and mental health, right? Clinical medicine and mental health. So 55-year-old woman with type 2 diabetes and hypertension presents with non-healing foot ulcers despite being prescribed wound care and glycemic control medications. She misses multiple follow-ups, stating she doesn't feel like dealing with it right now. What's the correct answer? Is it A? Is it B? Is it C? I think Dr. Benedicta, did you go with A first? No, I don't think so. I think Dr. Benedicta is going for A right now. And some people are also going for B. So I see that there's a battle between A and B. A and B. And what's the correct answer? It is poor immune function due to chronic stress and depression. Now, chronic stress and depression are associated with poor wound healing, immune dysfunction, and decreased control of latent infections. Now, what about B? Because a lot of people also went for B. Why is B wrong? Diabetes-induced neuropathy can delay wound healing, but her behavioral non-adherence is the major factor in this case. And because she's not taking her medications, her diabetes is worsening. And because the diabetes is worsening, her immune function is getting poorer, because we know that diabetes, like, you stand the risk of becoming immunosuppressed, right, with diabetes. So it is one thing to the other. So this patient has chronic stress and depression, and it is associated with poor wound healing because of the poor immune function and decreased control of her latent infections. All right. Okay, good. So, doctors, before we move to the next point, I want to remind you tomorrow we have med drills. Tomorrow, med drills will be at 6 p.m. EST. Tomorrow, med drills, or will be, sorry, I said 5:30 p.m. So that would be like 4:30 in Saskatchewan, right? So please kindly make sure that you join the train. For all MedCognito candidates, it's totally free. This is my time with you. The candidates decided that they wanted us to deal with psychiatry in February. So tomorrow, 3 hours, and then on February 18th, another 3 hours, and then we conquer psychiatry. Don't forget, you're also doing regular psychiatry classes as well. But tomorrow, we're going to do med drills and we're going to tackle psychiatry from a totally different perspective. Last month, we did ethics, and this month we're doing psychiatry as well. Okay, February 10th, February 18th, come get drilled, bombarded, and thoroughly prepared for psychiatry part of MCCQE1 exam. It is free for all MedCognito candidates, but those who are not MedCognito candidates, with just a little token, you can use this link to register. Just scan it and then you are in. Okay, or if you want to register after the class, let me know. We'll give you access to the class. And even with those with just 1 month subscription, you can still get access to everything in MedCognito plus this free class tomorrow. All right, so let's go back to the consequences of psychological factors which affect medical conditions. Consequences. So one thing we have to understand is that psychological and behavioral factors can worsen medical illnesses in multiple ways. So think about it as a chain reaction. So for example, look at that patient who had diabetes, who was not taking the anti-diabetic medication, therefore had developed the low immunity, so it's a chain reaction. Okay, so all the time, remember this particular topic, that whenever the mind struggles, the body will suffer. Whenever the mind struggles, the body will suffer. Okay, so what are the complications of psychological factors affecting medical conditions? Number one, these psychological factors increase risk factors for disease. So that's why I put the cigarette sign there, right? So smoking and substance use. And then at times they may be so psychologically drained that they may overuse pain medications like opioids and NSAIDs. And we know that people can easily overdose on opioids, and people can also develop complications from NSAIDs like upper GI bleed, renal impairment, right? And they can also have unhealthy lifestyle choices. So they can be so overwhelmed with, the diabetes management that they'll go like, you know what, I'm not even going to move anymore. I'm tired. I'm not going to do anything. They can have poor diet. They can be obese, and then they can, in relation to the increased risk factors for disease, we are looking at complications of psychological factors affecting medical conditions. They can even develop poor sleep hygiene, and poor sleep hygiene can then lead to metabolic and cardiovascular disease. And they can have risky behaviors, whatever. Okay, I've been like a patient will say, I've been diagnosed with HIV. Now I don't care. And then they just keep going around and spreading it to other people. Unsafe sex leading to infections. Okay, so these are some of the issues. Number two, some of the other complications are that it affects how patients seek and follow medical care. What do I mean by that? Some people ignore symptoms and they delay seeking help. Okay, because they are so psychologically drained that they don't even want to go see a doctor. And others exacerbate their symptom, leading to unnecessary tests. So the stress of that particular medical condition is causing the person to come up with so many, symptoms. And the doctor is now doing this test and that test and that test and that test. And remember, in Canada, one other thing you'll be tested on is choosing wisely. How to choose your laboratory investigations, how you choose your imaging investigations, right? But then the patient can present with various things, and because of that, you may be requesting unnecessary tests. And it could also be denial of illness that can prevent early detection. So the patient may be having the headaches, and they say, oh, it's just my migraine. Let me just take some Tylenol. It's just my migraine. Let me just take my Tylenol. And then by the time the patient realizes, it's become a very, very big tumor. Okay. And number 3, some of the effects of these psychological strains is that it can put a strain on the doctor-patient relationship. A strain on a doctor-patient relationship. What do I mean by that? Patients with anxiety and depression may struggle to communicate symptoms clearly to their doctor. You know, they may either suppress the symptoms or they may blow it out of proportion, and the doctor will not know what to do. And it can lead to mistrust or hostility towards doctors, and it can delay proper diagnosis because the patient may go to this doctor and say, I don't like this doctor. So whatever this doctor has started doing, the patient stops it, goes to a different doctor in a totally different place, who is not aware of what the other doctor has done. All right. And then physicians may misinterpret symptoms as purely psychological, missing a real disease. And it also lowers treatment adherence and lifestyle changes. Because the patient is so psychologically overwhelmed, they may not even take their medications. Neglecting rehabilitation, where the patient may refuse physical therapy because the patient will say that, oh, I'm just tired and sick and tired of all these instructions Dr. Bruni is giving me. All right. And then others can also struggle to make lifestyle changes as well. And then for some people, it impairs recovery and rehabilitation because they have lack of motivation to recover. So they don't go to the treadmill anymore. They don't do what will help their recovery. And for some, it can lead to poor tolerance to pain and frustration and mental health struggles, which can interfere with physical healing. So now, doctors, I'm going to take you to defense mechanisms. This one, I will plead with you. I'm going to go through a lot of them. After that, I'm going to do a special quiz on this particular one because it's a very, very important thing that a lot of candidates mix up. Psychodynamic defense mechanisms. So let's start with this question. You have a 28-year-old woman who visits her primary care physician to discuss difficulties she's been experiencing in her interpersonal relationships. She reports that she often feels let down or betrayed by people she initially admires. For example, she describes a co-worker as the most supportive and talented person I've ever met. But after disagreement, she now describes the same co-worker as completely self-centered and fake. She denies hallucinations, delusions, or significant mood swings. On mental status exam, she appears anxious but cooperative. She has no history of substance abuse or major psychiatric conditions. Which defense mechanism best explains her behavior? A, projection. B, splitting. C, regression. D, reaction formation. E, rationalization. Let's go. Is it A? Is it B? Is it C? Is it D? Or is it E? What's the correct answer, doctor? Is it projection? Is it splitting? Is it regression? Is it reaction formation? Or is it rationalization? Dr. Muntu went for E. That's rationalization. Dr. Sabine went for splitting. Dr. Samantha Rodri went for splitting as well. And what's the correct answer? The correct answer is B, splitting. Splitting is correct because the patient is compartmentalizing her views of others, categorizing them as either entirely good or entirely bad. And this defense mechanism often prevents the integration of both positive and negative qualities in a single individual. Because we all know that even as human beings, we are not always good and we are not always bad. Even the worst person in your life, there are some good things that person can do, right? But then for the patient to just swing from one point to the other, no. Okay, what about projection? What is projection and why is projection wrong? Why is projection wrong? Projection is incorrect because the patient is not attributing her unacceptable feelings or impulses to others. So what is projection? Projection is when somebody has some unacceptable feeling about themselves, and they start pushing it on the other person, whether it's a husband to a wife, or a wife to a husband, or a co-worker to another co-worker, right? Okay, why is regression wrong? That's what I'm saying. Look, doctors, we need to know these definitions very well. So please make sure you pick your notebook and you're writing down these concepts very well. What is splitting? What is projection? What is regression? Regression is when there is no indication of reverting to an earlier stage of developmental behavioral thing which was not right. So for example, somebody goes through a particular situation and the person starts biting their fingernails. Meanwhile, that is not how the patient has been behaving in the past, right? So the person is falling back on some characteristics which are considered infantile, right? And then reaction formation is incorrect because there's no evidence of transforming an unacceptable impulse into its opposite. You know, where you can have something you don't like, and then you just totally transform it into, oh, all of a sudden I like this thing. And then rationalization. Rationalization is incorrect because the patient is not attempting to justify her views with plausible but false reasoning. So whatever, like, you know, maybe a candidate has not studied or did not study for the MCQE1 exam, goes in to write the exam, does not pass. Oh, and I see that at times, like on my Facebook as well. Then people will just start saying all sorts of things about the healthcare system in Canada, you know. And I'm like, okay, whatever. I'm not going to respond to this, right? Yeah. So splitting is when you see, like, the patient sees this is all good or this is all bad, or maybe one particular person, and today the patient is saying he's the best person after sliced bread, and the next one, oh, he's worse than the worst criminal in the world, you know, that kind of thing. Okay, let's go to the next question. You have a 50-year-old physician who is experiencing extreme frustration after a difficult interaction with a patient. Later that evening, he yells at his children for minor infractions, saying they never behave. Which defense mechanism is he most likely using? A, sublimation. B, displacement. C, rationalization. D, intellectualization. E, humor. So we are learning about defense mechanisms. Defense mechanisms. Defense mechanisms. 50-year-old gentleman, doctor, had a difficult day at the clinic. Now comes home and is just yelling at his children, yelling at his children, yelling at his children. What defense mechanism is he most likely using? A, sublimation. B, displacement. C, rationalization. D, intellectualization. E, humor. It looks like the answer is B, displacement. And almost everybody got it, displacement. So displacement is correct because the physician is redirecting his unacceptable frustration from the patient to his children, who are a safer target. When I say a safer target, it's like somebody who cannot respond in equal measure, right? The doctor knows that if he takes his frustration onto his patient, the patient can report him to the quality improvement committee or to the college, right? So he rather take it to his children who are innocent, and they go like, oh, you know, we don't know what we did, right? So he's displacing his anger on the children. And then we have sublimation. It's incorrect because there's no evidence of channeling frustration into a productive activity. So look at the difference. Displacement is channeling the frustration to a safer target which cannot respond in equal measure, right? But sublimation is channeling the frustration into a productive activity. So for example, this doctor, he was so angry that he came home and he just picked his lawnmower and he mowed the whole lawn, he mowed the whole community. You know, that is sublimation, right? And then rationalization is incorrect because he's not justifying his behavior with plausible explanations. Doctors, please, are we all following? I want to know. Are we all following? Are we all following? If you're following, I want to get your response. Are you all following? Are you following? Are you following? Because this is not, you know, out and out medical stuff. We're talking about electrolytes, blah, blah, blah. But it's a major objective. Please, Are we all following? Please, 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 please. And how is the lecture going for you? Is it revealing some stuff for you? Is it revealing stuff to you? Is it revealing stuff to you? Is it revealing stuff? Please, I want to know. If it is, just type, it's revealing stuff, because I really want to make sure that we are picking up stuff, right? And then humor is incorrect because there is no use of humor to cope with the frustration. So, like if the doctor is frustrated, you just start cracking jokes, right? Okay. Now, another question. You have a 29-year-old artist with a history of aggressive tendencies. He takes up boxing as a hobby, stating it helps me channel my energy into something constructive. Which of the following defense mechanisms best explains his behavior? A, reaction formation. B, sublimation. C, regression. D, undoing. E, intellectualization. Intellectualization, undoing, regression, sublimation, reaction formation. So it looks like we are getting it right. And the answer is sublimation, right? Sublimation is taking something, a bad experience, and turning it into a socially acceptable or constructive thing, right? Remember that we said regression is when the person reverts to earlier stages of development, like start biting their nails and. And the reaction formation is incorrect because he's not transferring aggression into an opposite feeling or behavior, right? Like you take something bad and you turn it totally like good. Oh, the person is like somebody has a boss who is bullying him, and because of that, his blood pressure is just going through the roof. And oh no, my boss is the nicest person in the world. That's reaction formation, right? Okay, good. So let's do a deep dive. Let's do a deep dive into psychodynamic defense mechanisms. Deep dive into psychodynamic defense mechanisms. And I really, really want you to focus on this because I'm going to do a special quiz, where you are going to provide the answer. I'm not going to give you MCQs. I want you to give me the answer so that I will know that you've really, really gotten this in detail. So we have primitive defenses and we have higher level defenses, okay? So the primitive defenses, these are defenses that are often unconscious and used in childhood and when people are under stress, all right? It is unconscious use, people use it when they are in childhood and under a lot of stress. And the higher level defenses are mature adaptive strategies and they can still have their issues, Okay, so now let's start with this. Let's start with splitting. Let's start with splitting. So remember we talked about splitting, and doctors, please, I need you to make notes. Please. I need you to make notes because I'm going to quiz you and you need to tell me the kind of mechanism the patient is using, right? So splitting is viewing people or situations as all good or all bad to avoid dealing with conflict. Oh, everything about this gentleman is good. Everything about this doctor is good, So a patient idolizes their doctor one day, but sees them as an entirely incompetent doctor the next day. That is splitting. Doctors, please, are we okay on that before I move on to the next one? That is splitting. Oh, he's the best doctor. I want all my family members to see him. He's the most caring doctor in the world. He has the best bedside manners. Or the next day, maybe the doctor gives a treatment plan which the patient does not agree with, or the patient was expecting something and the doctor gave evidence-based answer. The patient starts saying, oh, this is the worst doctor in this community, right? Number 2, projective identification is making someone else feel the emotions you cannot handle yourself. Making someone else feel the emotions you cannot handle yourself. So for example, feeling insecure and causing others to act in ways that reflect your insecurity. So you are very insecure and then you go around bullying other people, right? And you're hiding behind that veneer of bullying to hide your insecurity, right? Okay. Projection is attributing your unacceptable thoughts or feelings to someone else. Attributing your unacceptable thoughts or feelings to someone else. So someone is asking, Dr. Richard is saying, how different is this from borderline? So remember that we said that we are dealing with the topic psychological factors affecting medical conditions. All right. So for us to make that kind of diagnosis, we need to make sure that there is no underlying psychiatric issue. So you check, you do all your screening for borderline personality disorder, the patient does not qualify, and the patient has a particular medical condition and is exhibiting some of these defense mechanisms. That is it. Okay. Okay, someone says I should explain the previous slide again. Projective identification is making someone else feel the emotions you cannot handle yourself. Okay, so you feeling someone feels insecure and they are causing others to act in ways that reflect their insecurity. So for example, you have somebody who is insecure in relationships. They want to always be clingy, and because of that, they become so bossy that they it causes their subordinates to want to cling to them, right? That is projective identification. Okay. And then projection is attributing your unacceptable thoughts or feelings to someone else. So a person is angry at their co-worker and insists that their co-worker dislikes them. So I'm angry at this person, but then rather I'm turning it around and saying that that person rather hates me. Right? Please, doctors, write these down. Please write these down. I'm going to quiz you. Write these down. Okay. Next one, denial is refusing to accept reality to avoid pain. For example, you have a smoker who denies that smoking can cause lung cancer despite clear evidence, right? This person does not want to stop smoking. Therefore, he's denying the fact that smoking is bad. Okay. And then there's also disavowal. Disavowal is dismissing uncomfortable thoughts or feelings. So the patient is going through something very troubling, but then the person is dismissing the feeling of the fact that they are going through something very troubling. So it's like it's somehow like denial. Denial, you know the thing is bad, and you are just not wanting to accept it. Disavowal, the person is going through pain, but the person is ignoring the feelings of the pain or ignoring the feelings of guilt after making a hurtful comment. All right? Okay. And then we have schizoid fantasy. Schizoid fantasy, where someone escapes into that person's own imagination to avoid social or interpersonal stress. So for an example is daydreaming instead of engaging in an uncomfortable group discussion. So I dream and hope that this thing just goes away, right? Daydreaming instead of engaging in an uncomfortable group discussion. So maybe you're a group of doctors, so a conflict situation has come up, and instead of coming together to talk about it, this particular doctor is just wishing it away, daydreaming it away. Okay, that's a schizoid fantasy. Okay, and what about regression? Regression is reverting to earlier behaviors under stress. So, for example, a stressed doctor or a stressed adult starts biting their nails or throwing tantrums, right? They start biting their nails or throwing tantrums. And this is not a behavior this person had previously, but under stress, that person starts exhibiting that behavior. And then what about conversion? Conversion is transforming psychological distress into physical symptoms. Psychological distress, psychological stress into physical symptoms. So, for example, stress which is leading to paralysis or stress which is leading to loss of vision. You do all the investigations in the world. There is no medical reason why this patient should be paralyzed, but the patient is paralyzed. And then you can trace it and go back and you realize that this patient has, a stress in their life, And then you can say that, okay, maybe that is what is causing this. So before you can say this is conversion, you want to make sure that you've done thorough investigations. Okay? Okay, good. What about undoing? Undoing. Doctors, please write it down. Please, I hope you're writing them down. Please, I hope you're writing them down. I hope you're writing them down. Because we are going to quiz you on it. I hope you're writing all these things down, please. I want to make sure. Are you writing them down? Okay. So undoing is trying to reverse or cancel out unacceptable actions. So for example, you yell at a work colleague, and then the work colleague starts crying. And because of that, this doctor goes to buy a bouquet of flowers, roses, and all sorts of things, and brings it to this work colleague. Okay, trying to reverse or cancel out unacceptable actions. That is what we call undoing in psychological factors affecting medical conditions. Now, what about the higher level defenses? So these are the primary defenses. What about the higher level defenses? Rationalization. Rationalization, where people make excuses to justify unacceptable behavior. What do I mean? I failed the exam because the questions were unfair. That's what the person will say. Not that the person will say, oh, I didn't have time to study. I was taking up multiple shifts, in order to take care of my family. So I failed the exam because, oh, some people have some inside information and I don't have any information. No. But the truth is that because the person did not study, that is why the person did not pass the exam. All right? Okay. Displacement is redirecting emotions to a safer target. I described it. Yelling at a friend after being scolded by a boss, or yelling at your children after having a hard day at work as a doctor. That is displacement. Doctors, please. Are we all following? 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 Right? Okay. Next one. Intellectualization. Intellectualization is using logic to avoid emotions. So, for example, you have a doctor who has lost a mother or a father or an uncle, and instead of mourning the situation, right, he's focusing on, oh, the cost of, so, he's trying to make up for the emotions with, okay, so what do we do? Let me get into planning mode. Let me get into this. Let me call the funeral home. The person doesn't even want to deal with the emotions of the loss, right? So focusing on funeral costs instead of grieving a loved one. Okay. What about isolation of affect? Please write this down as well. Isolation of affect is separating emotions from thoughts. Doctors, please don't forget to like and subscribe to our YouTube channel right now. Like and subscribe to the YouTube channel. Please push us to 1,900. We are 1,857. Push us to 1,900. Okay, 1,900. That's all I'm asking from you. 1,900. Let's go there. Okay. So what is isolation of affect? It is separating emotions from thoughts. So, for example, like the person has gone through a very traumatic experience, and the person is describing that experience, but the person is not showing any emotion. Describing a traumatic event in their lives, but then it's not showing any emotion. When describing that, you go like, what is happening here? Right? What is happening here? Okay. And then sexualization. Sexualization. It is assigning sexual meaning to distract from uncomfortable emotions. So, there's an uncomfortable emotion the person is going through, but is assigning a sexual meaning to it. So turning a stressful situation into flirtatious behavior. Okay. Maybe the person is going through, whether divorce or whatever, and then now it's even pushing the person to now start chasing people of the opposite sex all through. Maybe that is not even the reason for the divorce, but the person goes like, whatever, to hell with this, and then he starts living a reckless life. through sexual inappropriateness. And then reaction formation is acting the opposite of how you feel. So, for example, there's somebody you dislike so much, but you become overly kind. Oh, how are you doing? But in your mind, you hate this person to the core. Okay? Reaction formation. You hate this person to the core. But then you have gone the other way. You are not even neutral. You've gone the other way. You are super sweet to the person. And then sublimation is redirecting unacceptable impulses into productive activities. So, for example, when someone converts his anger to boxing and becomes a world champion, sublimation, right? Channeling anger into sports or arts. So, Dr. Richard is talking about the devil and evil, something. Yeah. Okay. And then humor is using comedy to diffuse tension. Okay, making jokes during a stressful presentation of a patient, using joke or making jokes during a stressful presentation. And then anticipation is preparing for potential stress, where you are practicing answers before a job interview to reduce anxiety, or like all the doctors on this particular call right now, you know, the medical council releases practice questions on their website. You go by it. Anticipation, you start preparing because of the potential stress of the MCQ1 exam, right? That is a matured way of doing things. And then suppression. Doctor, so please make sure you've written all these things down. I beg you, make sure you're writing all these things down. So suppression is consciously ignoring emotions or thoughts, or setting aside worry about a diagnosis to focus on work. I'll deal with it later. I'll deal with this later. Okay, Dr. Katie says she missed the previous slide. That is preparation for potential stress. That is anticipation. And practicing answers before a job interview to reduce anxiety, or practicing answers before an exam, right? And then repression is unconsciously blocking unacceptable ideas or impulses. It is not done deliberately, like it's not even coming through. The person has unconsciously blocked it, where they forget details of a traumatic event, not consciously but subconsciously. All right. Okay. So, doctors, I'm going to quiz you on this because I want to make sure that you really got it. I'm going to quiz you on it. So please get ready to be quizzed. Do you want me to give you 1 minute to go get some water or something? Let me know. If you want me to give you 1 minute to go get some water, let me know. I'm going to quiz you on all these defense mechanisms right now. If you want me to give you some time to go get some water or stretch out, let me know, and then we'll do that. Okay? Dr. Isaac says yes. Okay, so I'm giving you just 1 minute. 1 minute is 2:07 my time, 2:08 my time. We start again. And the first question will go at 2:08. That is 3:08 in Ontario. So just go grab some water. Okay. While we are doing that, some people said I should go back to the previous slide. So yeah. Okay, so I'm giving you 1 minute, 1 minute, 1 minute, please. Oh, I thought this is the previous slide. Let me go to the other previous slide as well. Suppression. So 1 minute, 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 1 minute. Okay. Okay, so now let's go. 1 minute, let's go. Or someone says I should go back to repression. Repression. Dr. Benedicta, this is repression. Unconsciously blocking unacceptable ideas or impulses. Okay. Unconsciously blocking unacceptable ideas or impulses. Okay, so now I think we can go. But before that, before we do that mock, I want to let you know that you can have access to everything in MedCognito. And what do I mean by that? You can have access to our free med drills, okay, which is something we are doing on top of everything we've been doing in MedCognito, dealing with issues which you find as troubling, weak areas, okay? You're going to get access to our entire study portal. You're going to get access to replay of every live class we do. You're going to get access to extensive study resources, more than 200 hours of recorded lessons. You're going to get access to proctored mock exams, discounted price for MedCognito candidates, and we are starting in March. And that is how we've prepared our people for success, okay? Expert-led instruction and peer and tutor support on our WhatsApp page and in our Facebook group and everything. There are so many options. So even if you want MedCognito access for just a month, for 1 month alone, it's just $450. You get access to everything in MedCognito, including the med drills that particular month. You can decide to also get it for 6 months, but pay only $420 every month. And for those who want access for only 3 months, because the exam is coming up in May, we've created something for you, okay? So $1,350 every for 3 months, and then you are done. And then you go for your exam in May, boom, you are done. But if you want to stick with us for 6 months, just $2,199 one-time payment, or $420 every month for 6 months, and you're good to go. So we have so many options, and that is why I've made my phone number available. After this, reach out, because usually after a class, so many people reach out, you know. And so if you want, what I'll suggest is, if you like, reach out right away so that I can reach out back to you as soon as the class is done. Now let's jump into the mock exam. So I will share the link to all the payments when the class is done, and you can use that to register. So please reach out to me by WhatsApp +1 306 891 5649 +1 306 891 5649. Let's go. So I'll provide you the case. You tell me the answer. This time I'm not going to give you options because I want to make sure that you've really gotten it drilled in your mind. So let's go. A medical student fails their board exam and tells their peers the questions were unfair and they didn't test what we were taught in class. It wasn't my fault. Which defense mechanism is the student using to justify their failure? I'm not going to give you answers. I'm not going to say A, B, C, D, or E. So please now tell me the answer. And for every question, if 10 people give me the correct answer, I'll move on to the next one. So I've gotten one correct answer. One, Dr. Richard Kwame Asare. I'm not going to show your answer so that it will not affect other people. So 1, 2, Dr. Helen Besong. 3, Oreku also got it. No, Oreku, that's wrong. Good, Dr. Paramita got it right. Dr. Shaza also got it right. Dr. Izatu also got it right. Dr. Iba got it right. Dr. Sabine got it right. So many people are getting it right. Please, the answer is not repression. No, Reku, no. It's not repression. The answer is rather rationalization, right? So rationalization. The student is justifying their failure with an excuse instead of accepting their role in the outcome. So the answer is rationalization. Doctor, so please, this is how this part of the mock is going to go, okay? This is how this part, this is not how you're going to be quizzed in the exam, because the medical council says it's all going to be MCQs, but I'm just going through this route because I want to make sure that you are not doing any guesswork. Okay, next one. After being reprimanded by her supervisor, a resident goes home and starts yelling at her spouse over minor inconveniences, such as forgetting to take out the trash. Which defense mechanism is being displayed by the resident? I will only reveal the answer after 10 people have gotten it right. Okay, Dr. Mehu. went for, okay, now I will show people's answers, because so someone is saying displacement, someone is saying reaction formation, someone is saying displacement. Okay, Dr. Evelyn, someone is saying projection. So we have displacement, reaction formation, projection. What's the correct answer? The correct answer is displacement. It's not projection, it's not reaction formation, it is displacement. Why is displacement right? The resident is redirecting anger from her supervisor to a safer target, that is the spouse. Because the resident knows that if she goes and talks to her supervisor anyhow, that can be a serious disciplinary issue, right? So the resident is directing it to a safer target who will not speak back. That is the spouse. Okay. Next question. Please, doctors, are you okay with the way we are doing it? Please, are you okay? I want to know, because in my mind, I was like, we've gone through so many things. How can I make sure that we remember? So that's why I'm bringing up the questions this way. Are you okay with this? Are you okay with the way we are doing it? Okay, good. Good. Okay, let's go. A patient diagnosed with cancer tells the doctor, I've read all the studies about this type of cancer, and the 5-year survival rate is 70%. So there's no reason for me to worry. What defense mechanism is the patient using to avoid processing their emotions? Dr. Mehu says intellectualization. Dr. Limia says projection. Dr. Shiner says denial. Well, is the patient actually denying it? Looks like the patient knows that they have the cancer, right? So you see, I think when we are done with this class, please kindly take some time and go back and watch the slides again, okay? Because it looks like, yeah. So the answer is coming through. It's intellectualization, okay? This patient is focusing on logical data. That is the 5-year survival rate of 70%, instead of addressing their emotional reaction to the diagnosis. So the patient is depending on logical data. Doctors, it looks like some of the concepts, some people did not really get it well. So I'll suggest that please, as soon as this class is ended, just scroll back, go check it, review the slides that I was just talking about, the defense mechanisms one by one. This will not take you even 15 minutes, okay? Okay, good. Let's go again to the next one. A nurse describes a traumatic car accident they witnessed in a calm, detached tone, providing vivid details about the scene but showing no signs of emotional distress. Which defense mechanism is the nurse using to cope with the trauma? I like it. I'm not giving you any answers. So please look through the notes you took. What's the correct answer? What's the correct answer? What's the correct answer? That's what I want you to do. What's the correct answer, Doc? What's the correct answer? Let me also join you guys on YouTube and see exactly what you guys are doing there. What's the correct answer? Someone says isolation affect. Good. So it is isolation of the affect, right? Isolation of the affect. The person is talking about it as if like no emotions at all. Okay. And why? The nurse is separating their emotions, isolation, emotions from the thoughts and events they are describing. All right? Okay. A student feels deep resentment towards their classmate for always outperforming them academically. So maybe you go for group meeting, you're so angry that this guy is always getting the answers right. Instead of expressing their resentment, the student goes out of their way to praise the classmate publicly and acts overly friendly towards them. Which defense mechanism is the student displaying? Which defense mechanism is the student displaying? Which defense mechanism is the student displaying? Look at you guys go. I really like this. You know, when we teach something which is not very common and people are picking it up, it's beautiful. So that is reaction formation. This is beautiful. This is beautiful. I really like that. Reaction formation, right? Reaction formation. So the student is behaving in a way which is opposite to their true feelings. Reaction formation. Doctors, please. I hope today's class has been very helpful. So this concept can never beat you in class in the exam again. It can never ever beat you in the exam again. Okay? Okay. Next question. A competitive athlete channels their anger from losing a game into intense training sessions, striving to improve their performance for the next competition. What defense mechanism is the athlete demonstrating by converting anger into productive activity? You know, I thought the class was going to be boring, and people would say, "Oh, Dr. Body, you're not talking about sodium and potassium and electrolytes and ECGs," but it looks like it's something very, very good, because it's an MCC objective, and because of that, we need to focus on it. So what's the correct answer? What's the correct answer? What's the correct answer? I see a lot of people going with sublimation, sublimation. And what's the correct answer? Beautiful, sublimation, right? Sublimation. So it looks like people took notes. So it's the athlete is redirecting his unacceptable impulses, that is his anger, into socially acceptable and productive behavior. Okay, next question. A patient about to undergo major surgery jokes with the surgical team saying, "Hey, make sure you don't leave any tools in me. I'm not a toolbox." All right. So what defense mechanism is the patient using? Oh, oh. What defense mechanism is the patient using? Okay, this is humor. I gave it away. Okay, the patient is using comedy to reduce and cope with their fear. Next question. A medical intern who will be presenting a challenging case to senior physicians spends days rehearsing their presentation, preparing detailed slides, and practicing responses to tough questions. Which defense mechanism is the person using? The person has a serious presentation, and the person has been going for days rehearsing, blah, 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 blah. What's the defense mechanism? And the correct answer is anticipation, right? The intent is preparing for a stressful situation to reduce anxiety and to improve their performance. Next question. A medical resident reviews news of a family emergency during rounds, but decides to stay focused on patient care and address the personal issue after completing their duties. So maybe this intern was at work and was told that, "Hey, your dad has had a stroke." Okay, whatever. The person continues working and says that he will deal with it at the end of the day. What's the correct answer? So we have disavowal, we have suppression, we have intellectualization, we have suppression, disavowal, we have repression. So the answer is suppression. Suppression. The resident is consciously setting aside emotions to focus on their immediate responsibilities. Okay, so he's pressing it down, and then when work is done, then he'll bring it up again. Doctors, I'm very happy about the way you are participating in this class. Seriously, it's powerful. Okay, so a patient who experienced a traumatic event as a child cannot recall any details of the event when asked during therapy. Which defense mechanism is preventing the patient from remembering the traumatic event? Whatever traumatic event the person is going through, the person cannot recall any details of it. Any details. Any details. And what's the correct answer? So the correct answer is repression. Repression. Dr. Paramita, you are getting everything right. And Dr. Sabine as well. So many people, I'm very, very happy. We are doing something right. Okay. All right. So the patient is unconsciously blocking the memory of the traumatic event from their consciousness. All right, so doctors, that was a very good one. That was a very good one. That was a very good one. Please clap for yourselves. Clap for yourselves. That was a very, very good one. Don't forget to reach out to me after the class, because so many people will be calling. So +1 306 891 5649. I'll prefer a WhatsApp message, okay? So I can respond whether you're in Canada or outside Canada. So now let's look at the differential diagnosis of psychological factors affecting other medical conditions. Please, are you tired? Do you want us to do this last part, or you want us to call it off? I want to make sure we've already done 1 hour 24 minutes. I don't want to keep you if you are tired. Okay, so let's go on. So I'm going to use MCQs to take us through this. So a 34-year-old woman with mild asthma presents to the emergency department with shortness of breath and wheezing. She states that her symptoms began after an argument with her spouse. The physical exam confirms expiratory wheezing, and she improves after receiving bronchodilators. She denies being overly anxious about her asthma in general and attributes this episode to emotional distress. What's the most appropriate diagnosis? A, adjustment disorder with anxiety. B, illness anxiety disorder. C, psychological factors affecting other medical conditions. D, functional neurologic symptom disorder. And E, somatic symptom disorder. So I see C, I see D, I see C, I see C, I see C, I see B, I see D. The correct answer is C, psychological factors affecting other medical conditions, right? Because the patient's asthma attack was triggered by a psychological stress. Remember, we said it is psychological stresses which can make a particular medical diagnosis worse. You know, that is it. What is adjustment disorder with anxiety? Adjustment disorder is incorrect because psychological distress did not result from the asthma. So adjustment disorder is when there is a medical diagnosis which is leading to the psychological issue. But this one, it is a psychological issue which is making the medical diagnosis worse or bad. Okay. Now, what about illness anxiety disorder? It's incorrect because the patient is not excessively worried about having a serious illness. It looks like the patient knows that, hey, I have asthma and this is how things present. And then functional neurologic symptom disorder, that is conversion disorder, is incorrect because the symptoms are compatible with a recognized medical condition. In functional neurologic symptom disorder, the patient will present with neurologic features and you will do all your investigations and they'll be fine. Okay. And then somatic symptom disorder is incorrect because her thoughts or feelings about the symptoms are not excessive or disproportionate. Okay. The patient's thoughts are not excessive or disproportionate. Okay. Doctors, so we've hit 1,861. Please help us to hit 1,900 subscribers today. All right, let's go to the next question. 28-year-old man presents with seizures that occur during periods of emotional stress. His wife reports that he often appears to shake uncontrollably but remains fully conscious and able to respond to verbal commands. MRI and EEG results are normal and there is no evidence of epilepsy. What's the most likely diagnosis? A, epilepsy exacerbated by stress. B, somatic symptom disorder. C, functional neurologic symptom disorder. D, illness anxiety disorder. And E, mental disorder due to another medical condition. What's the correct answer? Is it A, Is it B? Is it C? Is it D? Is it E? The answer is C. The answer is C. Functional neurologic symptom disorder is correct because the patient's seizures are incompatible with epilepsy. Okay, the kind of seizure, because in epilepsy you can't be having seizure and your eyes are like you are still no. So this patient's functional neurologic symptom disorder is correct because the patient's seizures are incompatible with epilepsy and appear to be stress induced. So it is psychogenic non-epileptic seizure. That's what the patient has. Okay, and A is incorrect because there's no evidence of a medical condition such as epilepsy. The patient does not really have epilepsy because it says MRI and EEG were all normal. And then B is also incorrect because somatic symptom disorder is incorrect because these symptoms are not accompanied by excessive thoughts, feelings, and behaviors of the physical effects of the disease. So, doctors, these are some of the differentials of psychological factors affecting medical conditions: somatic symptom disorder, conversion disorder, functional neurologic symptom disorder, illness anxiety disorder. Illness anxiety disorder is also incorrect in this situation because the patient is not preoccupied with having or acquiring a medical illness. And E, mental disorder due to another medical condition, is incorrect because the symptoms are not direct results of a medical condition. All right? Okay. Next question. You have a 45-year-old woman who presents with chronic fatigue, chest pain, and palpitations. She has undergone extensive workups, including cardiac stress tests and lab investigations, all of which were normal. She frequently checks her pulse and blood pressure multiple times a day and avoids physical activity out of fear of having a heart attack. Which of the following is the most likely diagnosis? A, psychological factors affecting other medical conditions. B, illness anxiety disorder. C, somatic symptom disorder. D, adjustment disorder with anxiety. E, functional neurologic symptom disorder. That is conversion disorder. Chronic fatigue, chest pain, palpitations, undergone extensive workups, including cardiac stress tests and lab investigations, all of which were normal. This patient frequently checks her pulse and blood pressure multiple times a day and avoids physical activity out of fear of having a heart attack. What's the correct answer? So look at this. This patient is having chronic fatigue, chest pain, and palpitations, right? Now, the answer is C. Why? Because the patient is excessively preoccupied with her symptoms and exhibits maladaptive behaviors such as checking the pulse frequently and avoiding activity, right? The patient is, why is illness, and because a lot of people are going for B. A lot of people are going for B. Why is illness anxiety disorder incorrect? Because her symptoms are not minimal or non-existent, right? In illness anxiety disorder, the patient thinks he has a brain tumor, but the patient is never having a headache. The patient thinks he has diabetes, but the patient is not having any polyuria, no polydipsia, no frequency of urination, right? That is it. And then adjustment disorder with anxiety is incorrect because the symptoms are persistent and disproportionate, not a response to a specific stressor. Okay, next question. You have a 52-year-old man with hypothyroidism, presents with depressed mood, fatigue, and weight gain. His thyroid stimulation hormone is elevated markedly. After optimizing his levothyroxine dose, his depressive symptoms resolve. What's the most likely diagnosis? A, major depressive disorder. B, psychological factors affecting other medical conditions. C, somatic symptom disorder. D, mental disorder due to another medical condition. E, illness anxiety disorder. So this guy had hypothyroidism, and he was presenting with depressed mood, fatigue, and weight gain. His thyroid stimulating hormone is markedly elevated, and after optimizing his levothyroxine dose, his depressive symptoms resolved. So he was presenting with a medical condition, which is hypothyroidism, and after he treated the hypothyroidism, the associated mental health issues also resolved. Okay, what is the diagnosis? And I see a lot of people going for D, and the correct answer is D. This is a mental health disorder, mental disorder due to another medical condition. So it's like somebody with hyperthyroidism who develops anxiety, right? Yeah. So that's D. Mental disorder due to another medical condition is correct because the depressive symptoms were caused by the hypothyroidism, as evidenced by their resolution after thyroid hormone correction. Why is illness anxiety disorder wrong? That is E. It's incorrect because there's no evidence of excessive anxiety about having or acquired an illness. Right? Okay. So doctors, that is it for today. Don't forget that you can reach out to me right away. In fact, as we speak, let me finish the class and then you can just give me a call and then we can talk through what you need. Remember, tomorrow there's med drills. So if you register today, we'll add it to the team or we'll add it to the list. And you may not be a MedCognito candidate and you still want to register for the med drills. That's also fine. You can still register. It's only $199 for both classes. So you pay just once and then you're good to go. Okay, doctors, thank you very much. Reach out right away. Reach out right away. Because if you reach out late, I'll be on the phone with someone else. Thank you very much for reaching out today. Thank you very much for spending your afternoon with me. Please, those in MedCognito, remember tonight you have a class, okay? You have a class. Let me just check the time. Let me just check the time for you. You have a class tonight. Let me just check the time for you. Let me check the time. So tonight's class is, today is February 9th. Today you are doing pediatrics 2. Pediatrics 2. So please revise your pediatrics 2. Go to class. The time will be at 6:30 p.m. EST. Okay, so that means you have barely 3 hours to go. All right. So I'll leave you. Doctors, please reach out to me right now. Reach out right now. Let's talk. Reach out right now. Let's talk. Okay. Just reach out and let's talk. Thank you very much. Have a good day. I'll expect your messages on WhatsApp. Let's go. Let's go. Thank you very much. And share that. You can go back and review the video as well. Thank you. Thank you. Thank you. Have a good day.